Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. Good morning, everyone. It's a great pleasure to be here today. Really thank the organizing committee for inviting me to be part of this nice group. It's as well an honor and as well a challenge to present such a topic in front of my teachers and mentors. Just going in the same flow of thoughts that was presented already by Dr. Bakari, just trying to, as well in the same flow of optimizing IBD therapy, talking about the old and the new friend of us, which is steroid, that I think everyone in the room has used for their IBD patients. We'll just go briefly over discussing the steroid use in IBD, but mainly I will switch gears later on to introduce a web-based tool that will help in monitoring steroid use in inflammatory bowel disease patients. So, corticosteroids is an old friend, as I mentioned. It was the first clinical use of it was in 1930 when the scientists at that time were extracting the adrenal, cortex tissue from animals, and they needed like hundreds of cattle to just extract few cc's of steroids, and there was like the evidence in 1930 was showing that this extract was used to treat patients with adrenal failure to start with. 18 years later, 1948, the first patient with rheumatoid arthritis was treated with cortisone. Later on, they were able to synthesize more synthetic steroids that we currently use. The guys who discovered that got the Nobel Prize for their discovery. Dr. Kendall, a chemist, and Dr. Hench, both from Mayo Clinic, and Dr. Richstein from Switzerland. It was not until 1954 where Dr. Truelove and Dr. Witts, the British gastroenterologist from Oxford, who are famous with their scoring system for classification of severity of ulcerative colitis, where they first looked in a first trial looking at the steroid efficacy in UC. 12 years later, it was as well used in Crohn's disease patients. So the treatment goals for IBD has been evolving, as been mentioned earlier by Dr. Bakari, and we are moving from just simply improving the symptoms and quality of life toward hoping to achieve a complete clinical remission. And now most of the guidelines are endorsing trying to achieve a steroid-free remission and further to mucosal healing and as well deep remission. All of this with hopefully avoiding as much surgery as possible, decrease hospitalization, and with no complications or disabilities. So as all of us know, corticosteroids in IBD are used only for induction. It's not approved for maintenance. This is just counter-screen of some of the guidelines. So the American College of Gastroenterology 2018 and their Crohn's disease and UC guidelines, they are clearly endorsing that corticosteroids are not used for maintenance. They're used just only as an induction agent. And as well in the ECHO guidelines for UC 2017 and Crohn's 2016, they're clearly aiming for maintenance therapy, which is steroid-free. These are just kind of like, I would say, make sense principles for glucocorticoids use in IBD. Try to use an effective dose. Do not start small dose hoping for an effect. As well, do not overdose. So there are data suggest of proving that 1 milligram per kg is as effective as 60 milligram or 40 to 60 milligram has been dosed by guidelines. So try not to overdose. As well, do not treat for excessive short periods. So it's not bronchial asthma where we give just 5 days. Try to give them a proper dose with a proper tapering. And do not treat as well for excessively long periods, just usually defined by 3 months. So try usually to taper within 3 months has been endorsed by the guidelines. In the same, as well way that as you need to anticipate side effects and discuss them with your patients, teach them about the side effects and the complication that might arise. Most of our patients there's a cheap medication. It's still accessible through pharmacies and outside hospitals. So most of the patients, once they respond, they tend to continue on the medication. Some of them may be forgetting about how bad they might get if they continue on those steroids, especially in high doses. Outside the context of IBD, I remember seeing patients who was on steroid high dose for 3 years and came with all of the complications expected. So definitely teaching the patient about steroids is of paramount importance. So this is maybe a famous slide. All of us know the side effects and the the multiple adverse effects that are associated with long-term corticosteroid use, ranging from mental effect to skin and as well endocrinological effect, to an increased risk of infection, increased risk of venous thromboembolism, and etc. This is just, so we'll just try in the coming 1 minute or so discussing one of the large cohorts from the United States that looked at the corticosteroid use in centers in US. They reviewed around more than 30,000 patients with inflammatory bowel disease over 8 years. They did that in a retrospective design. And they looked as well at the rate of complications that are associated with the steroid use. They found that almost third of patients had required at least one course of steroids in that time window, and 17% out of those third patients had a prolonged course defined as more than 3 months. What they did, they looked at the rate of complications 1 year prior to the IBD diagnosis, then a year after the IBD diagnosis, and as well 1 year after steroid use. So here we're discussing the risk of venous thromboembolism among those patients, and you can clearly say, like you can clearly as well like observe here among the non-steroid users that patients, once they are diagnosed with IBD, they have a higher risk of venous thromboembolism, as it is doubling, but among steroid users it is tripling. So if you look at here, those patients who are using steroid, their risk of venous thromboembolism was 3.1. It tripled to 9 after a diagnosis of IBD, but it went further 1 year after the steroid use. Looking at the fracture risk as well, you can see that among the non-steroid users, patients with IBD has a higher risk for developing fracture, but this is more evident among steroid users, and this is clear 1 year after steroid use. And last is risk of infection, and you can clearly see as well the same effect happening with steroid use, reaching up to 63% risk of infection 1 year after using steroid. I'll just go now to the monitoring steroid use. We'll discuss one of the audit studies in UK that introduced this web-based tool that I will talk about. So this was a prospective multi-center audit that was done in UK in 11 centers. They enrolled 1,176 patients in outpatient settings over 3 months. Their aim was to measure steroid use among those patients, as well to assess the factors associated with the excess exposure. So in collaborative work among this group, it was called Treat Beyond Symptoms. It was one of the programs for quality improvement in IBD patients in UK. It was as well sponsored by ABDI. They developed this web-based or online steroid assessment tool that is like the user-friendly, doesn't have a lot of questions to fill, like 4 to 8 questions to fill, and it's easy to be done in outpatient settings. And we'll introduce the tool later on at the end of the presentation. So their study definition, they defined steroid dependency or excess in accordance with ICWA and UK guidelines as the presence during the 12-month period preceding the clinic visit of one or more of the following. So if the patient is meeting one of those over the 12 months or the 1 year prior to presentation to clinic, they were considered as steroid dependent or has excessive use of steroid. So if the patient has more than prescription of steroid course within the last year, so if they have one, they will not be included. If there's more than one, they will be included. Inability to wean steroids below 10 milligram per day of prednisone or 3 milligram per day of budesonide within 3 months of starting steroids. So if the patient continue on that dose beyond 3 months, they are considered dependent or excessive user. And if the patient flared their disease within 3 months of stopping steroid as well, they were considered dependent or excessive user. So this is just a simple characteristic of the patients, and you can see here that most of the patients were of the mild disease. They had just mild severity, we had almost only just maybe fifth of patients had moderate to severe disease. So looking at now at the steroid use among those patients, we can see that almost similar to the US data that was retrospective, almost a third of patients had a use of steroid at any given time. And out of those, almost 14.9%, almost 15% of patients were considered steroid dependent or excessive users. Looking at those patients with moderate to severe disease, 65% of patients had used steroids over 1 year, and 35% were dependent. Clearly, you can see the difference here that having a moderate to severe disease was associated with more steroid use. Later on, they did something else. So they came to those 14.9% patients who were like 175 patients, and they did one thing. They reviewed them by a blinded peer, so another co-author who was blinded to the patients, looked at the data, and they assessed whether the steroid use was appropriate or not. And they came up with those graphs. So looking at the whole group of patients, and remember the 14.9% that we were talking about earlier in the table before, and they divided them whether the patient had the steroid was given with a proper indication, so it was unavoidable, or it was given for another indication other than IBD, for rheumatological illnesses, for asthma, whatever. So those are considered appropriate or appropriate to use steroid. And then patients who were considered that probably like they were able to avoid steroid course or definitely avoiding steroid, and they collected them together, and they total 7.1% of those patients of the total cohort had an inappropriate excessive use. Then later on they took it further and they looked at the moderate to severe group of patients, and you can see that the inappropriate excess was reaching up to 16.3% in moderate to severe cohort. Sure. So they looked as well at the predictors of steroid use, and you can see clearly that having a moderate to severe disease, as we mentioned earlier, was associated with increased excess of inappropriate excess of steroid use among UC and Crohn's disease patients, as well having trainees in gastroenterology was associated with mild increased risk of steroid dependence and excess, and having dedicated IBD clinic was associated with less, or it was protective to avoid against inappropriate excess use of steroid among UC patients only. So just I'll skip now quickly to the introduction to the SAT, which is a steroid assessment tool. You will be able to get an access to this tool by approaching the medical team in an AbbVie outside. So first, once you just type steroid assessment tool in Google or in the address bar, you will have this page. You will put your name and your password. This will take you to the second page. Then you will enter your patient. You can enter the patient number. You can choose to be anonymous. If you choose the patient to be anonymous, you'll not be able to make another entry on the same patient because he will be anonymous. So maybe it's advisable, since it is to really respect the confidentiality and privacy of patients. So you are the only one who will access those data. So once you put the patient number here, it's better to use either a specific ID or the patient hospital ID for that. Then you start a new questionnaire. It will take you to 8 questions to answer. For example, this patient I choose Crohn's disease. Then you will fill the medication the patient is taking, whether he's taking them currently or previously or haven't taken them. Then you fill that. Then you choose the disease severity at last measurement, and then whether the patient has received any oral corticosteroids over the past 12 months or not, and whether he had co-prescribed bomb protection medication with their steroid course, and how many courses of steroids has the patient received over the last 1 year. And what was the longest duration? So for me, just to choose 3 months. And again, whether the patient was able to reduce steroid below the equivalent dose, just to whether to label them as dependent or not. And then you will have the summary of this. Now, once you are done, let's assume that doing that in an outpatient setting, either by you or by one of the trainee or by a dedicated IBD nurse, if possible, then you will have, once you just click submit, you will have the patient entered already successfully, then you can enter the second patient. But if you like to look at the statistics, So you can see here, it will take you to this page of statistics, and it will show you how many patients have never used steroid among your patients. So this is just a demo of 342 patients were entered, kind of like, it was haphazard entrance, it was not real patients, kind of like a demonstration. So 11% of patients, for example, in your center have never used steroid, 68% has used steroid excessively, and 22 has used steroid at least once but appropriately. Then further, just like for sake of time, you can as well has specific data concerning every single question. I mean, later on, I mean, like even like eventually you can get individual patient data by looking at the patient's individuals. They will be highlighted in green if they never use steroid, yellow if they use steroid properly, or red if they use steroid excessively. So this will kind of alarm you. So if your training, for example, filled that, you can come later on and identify those patients who used the medication inappropriately or the steroid excessively. So you can identify them and correct that, and you can use the whole data as well for further study and analysis by exporting the data to an Excel sheet. And I will just conclude here. Thank you very much.